Welcome to the Deep Dive. We're here to sift through the noise and really pull out the crucial information so you can get genuinely well-informed fast. Today, we're tackling something quite personal for many, but it also has huge public health implications. We're talking about falls in older adults. Now, when you hear fall, maybe you picture, a simple trip, a moment off balance. But for an older person, it's often, well, it's much more significant. It's not just a stumble. It can be a really pivotal event, like a sudden turning point that leads to physical injury, deep psychological trauma, and often, quite terrifyingly, a very swift decline in their independence.
You've really hit on a crucial point there. It's already a major concern for our aging population generally. But what we're diving into today is how this challenge, which is already urgent, becomes so much more complex and frankly, much more dangerous when cancer is part of the equation. We're focusing specifically on older adults who are also living with cancer. It's a group facing what our sources are calling a perfect storm of risk factors.
Exactly, and that's why this deep dive is so important for you. Our goal, our mission today, is to really unpack this heightened fall risk in this uniquely vulnerable group. We'll explore the complex reasons why it happens, what makes it so risky, and crucially, the essential multifaceted ways to prevent it. Prevention strategies that aren't just, an afterthought. As our sources really stress, prevention in this context isn't just some add-on to cancer care, it's fundamental. It's key to preserving quality of life and maybe even improving survival for these patients.
Absolutely. So where do we start? To really get a handle on the magnified risk for older adults with cancer, we first need that baseline. We need to understand what makes the general older adult population susceptible to falls in the first place.
Okay, so the baseline risks. What are we looking at?
Well, the natural aging process itself brings some key changes. Things like sarcopenia, that's the age-related loss of muscle mass and strength, and also a natural decrease in bone density. Plus, our reaction times tend to slow down, and there can be impairments in vision, obviously, but also in proprioception.
Proprioception, that's the body's sense of its position, right? Like where your feet are without looking.
Exactly, your body's sense of itself in space. And when that's impaired, along with slower reactions and weaker muscles, or you can see how stability is compromised, makes a fall more likely.
And it's not just those sort of normal age-related changes, is it? It seems like chronic conditions often pile on top of that, making things worse.
Oh, definitely. They compound the risk. Conditions like arthritis, diabetes, cardiovascular disease, they're very common, and they directly impact mobility and balance.
Okay.
And then there's a really big one, polypharmacy.
Right, taking multiple medications.
Yes, the concurrent use of multiple drugs. Our sources point to this as a major contributor, mainly because so many common medications, even ones that seem harmless, can cause side effects like dizziness, drowsiness, or orthostatic hypotension.
Orthostatic hypotension. That's when your blood pressure drops suddenly when you stand up.
Precisely. Makes you feel lightheaded, unsteady, ready to potentially fall. So it's not just the number of pills, it's the side effects adding up.
So it's the types of medication, too, and the consequences of a fall. There's so much more than just, a bruise or a scrape. The sources paint a pretty stark picture. Hip fractures are common, traumatic brain injuries.
Devastating injuries.
But there's also this insidious psychological piece, the fear of falling again.
Yes, that fear is pervasive. And it can develop after just one incident, even a minor one. And the terrible irony, the paradox, is that this fear often leads people to become less active.
Because they're trying to be careful.
Exactly. But reducing activity leads to further deconditioning, more weakness, worse balance, and that actually increases their risk of falling in the future.
It becomes this really vicious, self-perpetuating cycle.
It truly does. Which brings us squarely to the cancer magnification effect. When an older adult gets a cancer diagnosis, all those baseline risks we just talked about, they get amplified profoundly. And it's not just the treatment that's the issue initially. The cancer itself can directly undermine stability in some surprising ways.
Okay, so before even starting treatment, how does the disease itself directly cause problems with balance or falling?
Well, think about primary brain tumors or perhaps cancer that is spread to the brain metastases. These can directly mess with motor control, with balance, even cognitive processing needed for safe movement. A small growth in a critical area can have a huge impact.
Right.
Or consider bone metastases, particularly if they're in the spine or the long bones of the legs. They can cause what we call pathological fractures, bones breaking under normal stress or just severe pain. And that pain dramatically alters how someone walks, their gait, their mechanics.
They're literally compensating just to move, which sounds unstable in itself.
It is. And beyond those direct physical effects, in specific locations, you have these broader systemic impacts of cancer. Things that affect the whole body and just seem to sap a patient's strength and reserves.
Okay, like what? What are the big systemic issues?
Two major ones highlighted consistently in our sources are cancer-related fatigue, CRF, and cachexia.
CRF, I've heard of that. It's not just being tired, is it?
No, not at all. It's this persistent, profound exhaustion. It's not relieved by rest or sleep. People describe it as overwhelming, like nothing they've experienced before. And cachexia, that's a severe wasting syndrome, loss of both muscle and fat.
Wow.
So both CRF and cachexia just rob patients of the physical strength and the endurance they need to maintain balance, or crucially, to catch themselves if they start to stumble. Imagine trying to react quickly when you're profoundly exhausted and your muscles are literally wasting away.
It paints a really difficult picture. So we've got the aging process, maybe some chronic conditions, the direct effects of the cancer, these systemic issues like fatigue and wasting. That's already a heavy stack of vulnerability.
It is.
But then the treatments themselves, the very things meant to fight the cancer, can also significantly undermine stability.
This is such a critical piece of this puzzle, a huge factor. Chemotherapy is often a primary culprit here, particularly due to a side effect called chemotherapy-induced peripheral neuropathy, or CIPN.
Peripheral neuropathy.
Nerve damage.
Yes, damage to the peripheral nerves, usually causing numbness, tingling, maybe pain, most commonly in the hands and feet. And the impact on falls comes mainly from the feet. Our sources use this really potent description. When your feet lose sensation, it's like navigating on pillows.
Wow, navigating on pillows. I can immediately grasp how disorienting that must be.
Exactly. Your brain isn't getting the proper feedback from the ground. It severely impairs balance. And it can be subtle, a hidden danger the patient isn't fully aware of.
And it's not only chemo, right? Other treatments must have their own impacts too. That's correct. Radiation therapy, for instance, can cause localized weakness, fibrosis, which is like scarring of tissues, and fatigue, especially depending on the area being treated, and surgical interventions, particularly the major surgeries like abdominal or orthopedic procedures. They inevitably lead to post-operative pain, significant weakness, altered biomechanics, all increasing fall risk, at least temporarily, sometimes for quite a while.
And then looping back to medications, even the drugs given to help manage side effects can add to the problem. We mentioned polypharmacy earlier.
Yes, they absolutely compound that polypharmacy issue. Think about potent opioids, often needed for cancer pain.
Sedation, dizziness.
Right. And antiemetics, the drugs used for nausea, often have similar side effects. And steroids, which are used quite frequently for various reasons in cancer care, can cause significant muscle weakness over time, especially with long-term use.
So the very medications meant to help patients feel better can inadvertently increase their risk of falling.
It's a difficult balancing act for the care team.
So if we kind of pull all these threads together now, the aging, the disease, the treatments, the supportive meds, what kind of patient profile emerges? What does this look like in daily life?
Well, it creates a patient who is often dealing with chronic fatigue, significant physical weakness, possibly pain. Maybe they're nutritionally depleted from the illness or treatment. And crucially, they might be sensorially impaired, struggling to feel the ground properly because of CIPN, maybe vision changes too. Our sources sum it up starkly. It's a profile primed for a dangerous fall.
Primed for a dangerous fall. That really lands.
It highlights that this isn't just bad luck. It's a complex, multi-layered risk that truly demands a proactive response, an integrated approach. We can't just wait for the fall to happen and then react.
Okay, so given this incredibly high vulnerability, prevention has to be the absolute cornerstone. It sounds like step one, according to our sources, is a really thorough, individualized assessment, going way beyond just asking, hey, have you fallen recently?
Much, much deeper than that. It needs systematic screening for fall risk as part of routine oncology care. This includes taking a detailed fall history. Not just if they fell, but how it happened, where, what they were doing. The circumstances matter.
Right.
A really thorough medication review is critical. And not just listing them, but with an explicit goal. Can we deprescribe? Can we substitute any high-risk drugs for safer alternatives?
Right. Actively looking to reduce risk.
Exactly. Then evaluating comorbidities, those other health conditions we talked about, and using standardized tools. The timed up and go test or tug test is a great example. It's simple, quick, objective.
How does that work again?
The patient just stands up from a standard chair, walks 10 feet, turns around, walks back, and sits down. You time them. Gives a really good snapshot of their mobility and fall risk.
Simple but effective.
Very. And finally, the physical exam needs to specifically look at things like lower extremity strength, their balance, their gait, vision, and actively screen for signs of CIPN. You have to look for it.
So once you've done that really comprehensive assessment, gathered all that information, you move to step 2, putting together a multi-pronged intervention plan. It sounds like it needs to cover medical aspects, rehabilitation, and the environment.
That's the key, multi-pronged. So medical optimization means things like actively managing pain effectively, addressing anemia if it's present, checking for and correcting orthostatic hypotension, ensuring they have adequate vitamin D and calcium for bone health is also part of it. And crucially, that medication list needs ongoing scrutiny. Not just once, but repeatedly reviewed by the whole team, oncologist, pharmacist, primary care, always asking, is this drug still needed? Is it contributing to risk?
Constant vigilance on the meds. Okay. And then rehabilitation. The sources seem to highlight this as maybe the most critical piece, where the real retraining happens.
It is incredibly important. Referrals to physical therapy PT and occupational therapy OT really should be standard practice for patients identified as high risk, not an afterthought.
What does PT focus on specifically?
Physical therapists design tailored exercise programs. These focus on safely building strength, particularly in the core and lower extremities, because that's vital for stability. And crucially, they do specific balance training activities. Things like Tai Chi, which has surprisingly good evidence, even adapted versions for cancer patients, can significantly improve balance and reduce falls.
Okay, Tai Chi, interesting. And occupational therapy, what's their role?
OT plays a vital complementary role. They focus on function, teaching patients how to perform daily activities more safely, getting dressed, bathing, cooking. They're also the experts in recommending appropriate assistive devices, canes, walkers, and importantly, training patients on how to use them properly. Just handing someone a walker isn't enough.
Right. Using it correctly is key.
Definitely. And OTs often do home safety assessments, looking for environmental hazards.
Which leads perfectly into that third prong, environmental modification. These sound like potentially simple changes that can make a huge difference.
They absolutely can. And they're often quite straightforward. Things like removing throw rugs, a classic tripping hazard. Getting rid of clutter. Improving lighting is huge, especially on stairs and in hallways, particularly the path to the bathroom at night.
Thanks, Ann.
Installing grab bars in the shower or tub and next to the toilet. Ensuring pathways are clear and unobstructed. These aren't complicated, but for someone unsteady, they are critical safety measures.
Simple, practical, effective. And the final piece, which feels absolutely essential, is education, empowering the patient and also their caregivers. Why is this so crucial?
It's crucial because awareness changes behavior. They need to understand why they are at increased risk, their specific risk factors. Empowering them means teaching them, for instance, to recognize the early symptoms of CIPN, like tingling or numbness, and report it immediately. Knowing when it's appropriate to ask for help, not trying to push through when they feel weak or dizzy. Always wearing supportive, well-fitting, non-slip footwear, even inside the house. No floppy slippers. And critically, encouraging them to report any near misses, stumbles, losses of balance, even if they didn't actually fall. Those near misses are warning signs.
So that active engagement from the patient and their support system, that communication back to the healthcare team is vital.
Absolutely. It can be the difference between catching a problem early and preventing a fall versus reacting after a potentially devastating injury.
Okay. So we've really dug deep here. We've explored how aging, the cancer itself, the treatments, how they all converge to create this profoundly elevated fall risk. When you pull it all together, what's the biggest takeaway for you from all this information we've discussed?
I think the biggest takeaway is that falls in older adults with cancer. They aren't just, unfortunate accidents. They shouldn't be seen that way. They are, in large part, predictable events. They stem from this unique, challenging convergence of aging, the disease process, and the necessary treatments. It's that combination, sarcopenia, maybe neurological issues like CIPN, the profound fatigue, chronic pain, polypharmacy, all piling up. It creates a level of risk that just screams out for a concerted, proactive, and truly integrated response from everyone involved in the patient's care. It demands we see the whole picture.
Right, seeing the whole person, not just the cancer. And the impact of taking this proactive, integrated approach, it's huge, isn't it? It's clearly about preventing fractures, avoiding hospital stays. Those are vital outcomes, obviously.
Absolutely.
But maybe even more importantly, reading through this, it feels like it's about preserving function, preserving that independence and quality of life that's so incredibly important for anyone, but especially someone navigating the really arduous journey of cancer treatment.
Precisely. It's about maintaining dignity, maintaining control over one's life as much as possible during a very difficult time. That's invaluable.
It really is.
And, this integrated, multi-pronged approach we've outlined for preventing falls in this specific population. It's incredibly comprehensive. It tackles a complex problem from so many angles simultaneously. It really makes you think, and maybe this is a question for you, the listener, to ponder. How could this kind of model, this holistic preventive strategy, serve as a template elsewhere? Where else in healthcare are we facing complex challenges, driven by multiple converging risk factors that could benefit from such a truly integrated proactive strategy, rather than just reacting after the problem occurs?